Lay down, mate. Right, so there's a whole PowerPoint that goes with this, but it's over there and we're over here, so I'll just chat away. So first of all, we'll talk a little bit about how they presume that dry needling works. Okay, and one of the first ways it works is through local mechanisms. So when you tap a needle into the skin, okay, it causes the release of calcitonin-generated peptide, which causes a dilation of the vessels within the skin itself, and then affects the deeper tissue surrounding that skin. So that's one of the first ways that it works. And you remember Brad talking yesterday, was talking a lot about dermatomes and myotomes and sclerotomes. And so that's one of the other ways that dry needling is presumed to have worked through, sort of sclerotomal, dermatomal or segmental innervations. So when I tap this needle into Jimmy's skin above his tibialis anterior, and Jimmy's pretty lean, so if he dorsiflexes for us, you'll see that needle's gone into the muscle even on a really light tap because the needle moves around. If it was just sitting in the skin, it'd just flop around. So ideally, if you're just going into the skin, you'd get it to that stage where the needle flops around. Okay, and that's one of the first effects where you get that local effect, which causes the vessels in the area that you've needed to dilate, and then that affects the blood flow to the deeper tissues as well. Through segmental input, basically what happens is the area of the skin here above Jimmy's tibialis anterior is around L4, L5 dermatome. Okay, the dermatomes aren't an exact science. And if you get onto Google and try to download an image, you'll get even more confused because every image will look different than each other. But they're within the realms of very close. So this is around L4, L5 dermatome, possibly more likely L4. That sends a message up to Jimmy's spinal cord, and it depresses the dorsal horn within the spinal cord. So any pain travelling from tissue from L4 that goes to synapse on Jimmy's spinal cord can't transmit because the dorsal horn's been depressed. Okay, and that's the segmental activation of dry needling. And so their other theory around that is that basically if Jimmy's got a trigger point within his tibialis anterior, which has a myotome of L4-5S1, that we can deactivate that trigger point because the embryological tissue shares the same segment. Okay, so a message travels into Jimmy's spinal cord, then travels up to his brain, but at the same time it travels out to the embryological tissue that shares the same segment. Okay, and that's really what you'd refer to as superficial dry needling. Okay, so you'd attempt to deactivate that trigger point within tibialis anterior by just putting the needle in the skin above the trigger point. You'll find that most massage therapists, and me included, just like to stick needles into muscles because that's what we do. Okay, so generally you'll then go deeper and into Jimmy's tibialis anterior, okay, and then you'll get the dermatomal input, and then we're going to get a myotomal input into the spinal cord as well. Then what happens is a message travels up the brain to Jimmy's brain. He does have one, which is lucky for us. Okay, and then you get descending pain control mechanisms, which would be through the release of beta endorphin and dynorphins, okay, which causes that general body nice, good feeling that you experience after dry needling, or if you've had acupuncture, you can experience after acupuncture as well. So that's a general pain response. Okay, so if Jimmy's got a tight tibialis anterior, it's a very non-specific pain response. It's just an all-over body pain response when we get those release of endorphins. And then the last mechanism is through central regulatory mechanisms within the limbic system within the brain, where basically that controls lots of your emotions. Okay, and it's why some people can have dry needling or acupuncture and feel really good afterwards, okay, because it's affected their limbic system. It's also why some people can have dry needling and curl up into fetal position and start crying for 30 minutes, which they'll feel good after they stop, but might not feel good whilst they're crying. Okay, and that's because of its effect on the limbic system. So it has a lot of effect, obviously, on our emotional levels. So, and obviously, the main reason as soft tissue therapists will use dry needling for is to deactivate trigger points within the musculoskeletal system. So you can even use, and you can see if you've got very good eyes, see this needle moving? Okay, that's basically tiny little fasciculations within Jimmy's tibialis anterior that might even indicate to me that there is a trigger point within Jimmy's tib, because that needle's not meant to move by itself. He's not contracting his tibialis anterior at the moment. Okay, he's just laying on the table relaxing. So normally when you see a needle happily dancing by itself, and Jimmy's used to this so I can do it, you'll come in and you'll thrust the needle and you'll try and activate a twitch response within the muscle. Okay, we're not getting one at the moment, so I won't cause Jimmy too much pain. But you can see he's not moving around too much. He's quite comfortable with this. So some of the feelings that you'll get will be numbness, tingling, some burning sensations, some fullness. The actual twitch response, which is an involuntary twitch. Okay, it's out of the control of the brain. It's like a knee-jerk reflex or any of our reflex testing within the body. Okay, that twitch travels up to Jimmy's spinal cord, and because it's a control mechanism or a protective mechanism, it sends the message out to his tibialis anterior and says, you need to twitch now, and Jimmy becomes aware of it as it twitches. Okay, whereas normally a message would travel up to the brain, Jimmy would interpret it, and then he'd go, you need to twitch. Okay, this bypasses the brain. Okay, the brain becomes aware of it as the actual twitch happens. So from the point of view of TMJ, okay, and normally you wouldn't go sticking pins into people's lateral pterygoids if they haven't had dry needling done before, especially considering its proximity to the central nervous system. But Jimmy's had this done before and he's quite comfortable with it. So the main muscles involved with TMJ are going to be your temporalis, your masseter, your lateral pterygoids, and your medial pterygoids. Okay, the ones that you're going to offload first is going to be temporalis and then masseter. Okay, and you need to offload them because they're both involved in bringing the jaw up, elevation of the jaw, and we need to get them nice and relaxed so that we can get that jaw to drop down so we can actually access lateral pterygoids through this little hole here, okay, which opens up for us when the jaw drops down. So I'll try and lean across Jimmy and do it on the opposite side where... Ferrari, you know I'll give it a try. So we're going to do temporalis first. You're going to look for triggers within temporalis. You're going to look through the masseter for triggers, okay, which has multiple triggers, and then we're going to go for lateral pterygoids. Okay, there's probably no need to do medial pterygoids, which you can either do angling down from where we're going to do lateral pterygoids, or you can access it intraorally, which we don't have time to do today. And I don't think Jimmy wants it done either, because he'd have to have a shot of vodka to sterilise his mouth. Obviously, if you look at TMJ problems, they're normally or quite often secondary to other problems within the body. Okay, so you're going to have a look at their overall posture. Okay, do they have upper cross syndrome? Do they have lower cross syndrome type B, which causes that forward head posture? So you can treat all these muscles, but it's probably going to return if you don't address their overall posture, which is contributing to the TMJ in the first place. There's lots of other muscles that refer to the specific areas that we're going to needle, such as sternocleidomastoid, and these anterior fibres which sit within traps, okay, trigger point 1. Okay, so you're going to address any of the muscles that refer to the jaw itself, and then you're going to look at their overall posture to see if their posture is contributing to their TMJ. Okay, if they're, depending on how long they've had TMJ, okay, they might have been a smoker and they've moved on to nicotine gum. Okay, is that contributing? You know, do they just chew gum regularly? Are they nail biters? Are they clenchers? Okay, are there any emotional disturbances going on, such as debt, that's caused this TMJ problem at the moment, which is probably something you can't deal with, okay, but trying to analyse what may have brought on their TMJ syndromes. But for the moment, we'll get to do some needling. So normally for this one here that I put in Jimmy's leg, okay, if I twist that, okay, the needle tightens up, okay, and you can't pull it out, okay, and that's because these are Chinese needles, okay, and there's probably some Chinese people in the room that I'll offend, but the Chinese manufacturing process is generally a lot poorer quality than, say, Japan or Germany. Okay, so those needles under extreme magnification actually look like fish hooks. Okay, but that's good for us because when we twist them, they grip the tissue and they give us lots of feedback. These needles that I'm going to use on Jimmy's face, because the face is a lot more sensitive, okay, it's a lot closer to his central nervous system. Okay, plus it's a lot closer to Jimmy's eyes, so he gets to see what I'm doing. So the first time people see you sticking needles into the side of your face, they don't really like it too much. So there's more of a chance that Jimmy's going to react to the needling process. Okay, he probably won't because I've done this before on him, so he should be fine. So you use sharper needles. So these are German needles, okay, and you put these under magnification, and they look exactly the same. Okay, they just look like a nice, smooth, Teflon-coated needle with no barbs in it. Okay, but when you twist it, it doesn't tend to grip.
So on the soft tissue website, there's a photo of the two different types of needles. You want to have a look. It's pretty amazing.
So temporalis itself, obviously fans from the temporal fossa, you know, around to posterior behind the ear, and most of its referrals, it has about 4 triggers in it, okay, and they all refer down to the teeth. Okay, so they give a teeth referral pattern. Okay, obviously I could glove up for the purpose of this demonstration and stick my fingers in Jimmy's ear and check how his jaw's moving, okay, which head of the mandible's coming back to my fingers first, but we're already 20 minutes over time, so we won't worry too much about that. I'll do it both sides. How's that?
Just let him suck on one of those.
So what do you pull out the Chinese ones?
You can almost make Jimmy look nervous by just rubbing over his nose.
That's disgusting.
It smells awful, doesn't it?
So Jimmy, did you know Helen Longevine did a study on acupuncture points, and she found that 85% of acupuncture points lie on fascial meridians and intermuscular septa. So they think possibly it might be how acupuncture points work on fascia.
On fascia.
They stimulated the needles, and they found that they measured how it affected tissue further away, and they measured changes or fascial movement or changes in tissue up to 10 centimetres away from the side of the needle.
Yeah, that was her research where they sort of also proved that, or they think that there's obviously when you twist the needle, it grips the superficial fascia,
yeah,
but doesn't actually grip deeper within the muscle.
Yeah.
But if you actually get a needle, the further you put it in, the more it grips.
Yeah.
So to me, I think there's got to be something that we haven't found yet,
Yeah.
because the further you stick a needle, the more it grips. So if it's only the superficial fascia, you'd think that no matter how far you insert it, the grip wouldn't change.
Yeah.
So I think the superficial fascia, because of its density, it's more obvious to pick up on ultrasound.
Yeah.
Is that Jimmy?
A bit tender, yeah.
All right, so masseter, as I said, has several trigger points, okay, a few within the deeper fibres, but the main one tends to be if you find the angle of the mandible of the jaw and you take a 45-degree inclination up towards their eyes, there's one that sits right within the sort of belly of the muscle itself,
Yeah.
just there.
Yeah.
Now on this you'll tend to, now if we look at this from a dermatomal point of view, or from a segmental point of view, temporalis, masseter, lateral and medial pterygoids are all supplied by the trigeminal nerve, okay, and all by the mandibular division. Okay, so as Brad was sort of talking about yesterday, this could be a TMJ problem, or it could be a trigeminal nerve problem, or it could be a postural problem. Okay, we don't know. But what you do is you know, as Daniel sort of said before, you start to add and minus and rule things out and work out whether you get changes and then try something else. Okay, so you might initially just try some sort of primary treatment on the TMJ itself, try and get some resolution, get no resolution, it returns, look at posture, it returns, look at diet, contributing factors, okay, and try and work out what's actually contributing. Because oh, he's back.
If he does have pain,
Mate.
it's because he's got braces on.
It could as well, but we can needle those.
Would it be indicated for someone with Bell's palsy?
They've done. There's not much out there on dry needling with Bell's palsy, but there's a lot with acupuncture and Bell's palsy. And the reality is that the difference between acupuncture and dry needling, the needles are the same. Our nervous system does not know the difference between me as a soft tissue therapist and someone else as an acupuncture therapist. Our nervous system's just not quite that switched on. A lot of the techniques are different. Okay, dry needling can be a much more aggressive treatment than acupuncture. Okay, like Japanese acupuncture, they'll just pretty much tap the needles in the skin and leave them in the skin, whereas Chinese acupuncture, in the video we were actually trying to get up before, was a guy with a 30 centimetre needle just trying to saw someone's deltoid off. It's on YouTube. It's quite. And we were going to pretend that that's what we were doing today to see who we could get to faint, but we couldn't actually get the computer to load up.
Get it on, Joe?
Yeah, it's up.
It's up?
Cool.
All right, so we'll watch it at the end. So we'll do the masseter. We won't do all the trigger points within the masseter. So generally what you do is you could offload these two muscles first. Okay, you could look at doing some PIRs on the muscle to try and get them to lengthen after you've taken the needles out. You know, your reciprocal inhibition. I tend to do more of your reciprocal inhibition, okay, with my TMJ rather than the PIRs. Okay, but in the end it probably comes down to someone's preference of what stretching techniques they want to do. And half the time you can't validate whether yours is any better than others. It's just what you choose to do. The lateral pterygoids, if you remember your jaw anatomy, which I'm sure not many of us do, okay, you've basically got the head of the mandible, okay, and then it curves down and forms a coronoid process, okay, which if you stick your fingers whilst you've got your jaw closed in here and open up your jaw, you'll find a bone that pops out into your fingers, and it's always quite tender. Okay, that's the coronoid process. Or when I was studying, I kept calling it the coracoid process because I just did. Okay. So that's your coronoid process. That's where temporalis attaches down onto. Okay, and when it pulls up on that coronoid process, it obviously elevates the jaw. Okay, so when you look at jaw opening, you obviously need to know the activation of the muscles. Okay, whether they're ipsilateral deviators or contralateral deviators. Okay, so you have got temporalis, which is a contralateral deviator. Okay, so it'll deviate to the opposite side, and then you've got a lot of the pterygoids, which are ipsilateral deviators. Or did I get that round the wrong way? Temporalis is a
Eversion,
Contra.
inversion, who cares?
yeah, hang on. Good work. Okay, so I'll just place my toes in the hole where they need to go. What you'll then do is when the jaw is closed, if it's under tension, okay, the masseter is contracted and it pushes your fingers out. Okay, so you try and get your jaw in what I refer to as the snoring or dribbling position. Okay, so it's that position in between fully closed and fully open where it starts to hurt, and it's that position where you wake up on the couch and you've got obviously drool coming down the side of your mouth. So it's that very relaxed position in between fully closed and fully open. And what that does is it drops the coronoid process down, okay, it brings the head of the mandible slightly out of its joint, okay, and it just increases that gap for us to palpate and access the lateral pterygoids. And what you'll find, as they open and close your mouth, your finger will just suck in and out of the hole. So if you want to try and locate it yourself, find your ear hole. Now make sure you find your ear hole, not any other hole. Okay, and come about 1 centimetre in front of your ear hole. Okay, as you open up your jaw, you should feel the head of the mandible pop out into your fingers, and you should also then feel your fingers sink into a little groove. Okay, that little groove will be just below the zygomatic arch. Okay, and you'll have that zygomatic arch which has a little curve in it before it forms your cheekbones. Okay, that's where you want to aim your needle, and you're going to get into lateral pterygoids through there. Now when you needle lateral pterygoids, you could get all sorts of different referral patterns, because essentially you're going to be going through masseter itself. You can't dodge it. Okay, so you're going through that sort of cutaneous distribution of the mandibular nerve. Okay, you're then going through masseter, which is supplied by the mandibular nerve. You'll go through the posterior fibres of temporalis, which is also supplied by the mandibular nerve, okay, and then you'll get into lateral pterygoids, which also has mandibular nerve. When you do these ones over on the jaw here, okay, you also end up tapping on the mandible itself. Okay, so we're doing a bit of sclerotomal stimulation. Okay, and the jaw itself, bone pecking, okay, periosteal pecking, bone pecking, or sclerotomal stimulation. Okay, obviously the bones are the sclerotomes, and the reason you do that again is because in this instance, that bone that sits below masseter, okay, is also supplied, has a sclerotomal innervation from the same nerve that we're working with, the trigeminal nerve, mandibular branch.
Do you have a problem? Like, what's his problem?
Well, I was meant to finish 24 minutes ago, and if we're going to go into that, all right. So normally I wouldn't work over the body. I'll do one on this side for you as well, Brad. So normally I wouldn't work over the body. Okay, so there's Jimmy's ear hole there. I won't stick my finger the whole way in. Okay, there I can feel that little groove within the zygomatic arch, and if I get Jimmy to open up his jaw, okay, my finger should drift into a little hole. And relax. You'll notice when they open up their jaw too far, the head of the mandible dislocates and comes forward and pushes your fingers all out of the way. Okay, when it does that, they've actually opened it up too far. Okay, you'll also know if you get the right hole, because we need to insert this needle in a fair way. And if it doesn't go in a fair way, that means I haven't got the hole. Okay, because I hit bone too quick. Okay, and I've misjudged my palpation. Okay, that needle's gone in. These are 30mm needles. That needle's gone in about 2.5 centimetres. So I've got that in the correct location. Want to come over this side, Brad?
Can you go in too far?
No, you'll just hit the teeth. So finding that little groove.
That's 100mm, Jimmy.
Not bad.
How's that?
That's good.
Okay, so that would be your initial treatment for TMJ, targeting the muscles more involved in the TMJ. Okay, from there, okay, I normally have a palpate through sternocleidomastoid. Okay, it's the deeper division. Now it depends. The deeper division of sternocleidomastoid refers into the ear. Okay, so if you've got someone that's got TMJ and also some tinnitus or some ringing, okay, then you're automatically going to go for lateral pterygoids, which is involved in, it sort of puts pressure on the little vibrating structures within the ear and can cause ringing as well, and so can sternocleidomastoid because it's referral direct into the actual ear hole itself, the auditory meatus. Okay, so if that was the case and someone had tinnitus, you'd palpate through sternocleidomastoid. Okay, I won't worry about needling, it's quite tight there in Jimmy, all those posterior fibres.
Thread it.
Thread it.
Yeah.
You can do one. And then we'll watch that video.
All right. So I'll wipe that sweat off. So when you're needling someone's sterno, you've always got these superficial veins that are in your way.
Don't move, Jimmy.
So the reality is on Jimmy at the moment, I don't know what's like on the other side, you can see superficial veins on the other side as well. So that's a bonus when you're needling Jimmy because you can actually see his veins. Okay, on a lot of people you can't. Okay, so you're not really going to know. So you're either going to go straight through them or you're going to dodge them. Okay, now the reality is you're not really going to damage their veins by putting these tiny little needles in. So if you can see them, dodge them, and if you can't see them,
Ignore him.
get a cotton bud ready. All right, so I'm going to just pincer pulp through Jimmy's sterno. Okay, now what threading is basically, if this is my normal muscle fibre, and I put the needle in perpendicular, and I twist it, I'm just twisting a small amount of the muscle fibre. Okay, with threading, what you'll do is you'll put the needle through the fibre itself. Okay, so you're really trying to target one taut band. Okay, rather than normally what you'll do is you'll go right into the middle of the taut band and twist it. With threading, you'll go through the taut band that way, and you'll normally go through the taut band in the opposite direction so that the needles are almost meeting and crossing over. And then you'll twist one clockwise and one anti-clockwise, so the fibres are actually twisting like that. And then you'll pull them apart to put the maximal amount of stretch on it. Now to do that, I've got to use the Chinese needles because the other ones grip too much.
Just shove that needle halfway through your hand.
You cannot hardly feel them anyway.
So you'll normally hold sterno in your hand because you want to draw it away from the
cough.
from the. Oh no! You just sucked the needle the whole way in. You want to make sure that you're drawing the sterno away from the carotid artery. Okay, you hold that in your fingers. See it? Okay, so I've got one coming from inferior, okay, and one coming from superior. So I'll twist up the first one. Can you see that on there? There we go. So I'll twist up the first one, and Jimmy's already getting that. Okay, so I've twisted the first one clockwise. So this bottom one I want to twist anti-clockwise. Okay, it'll bring on a very deep, dull ache, so more intense than most of the aches that you're used to. And once again, not something that you're going to do on a first time client. You build people up to this.
If you want to you can like twist it and then just get stuck in there.
And then you slowly draw the needles apart, which puts on a little micro stretch within the specific fibres that you're trying to target, rather than a normal stretching, which will be a very globalised stretch. Okay, so we're trying to stretch the specific taut band that's involved. And we'll just back those off. Now, I don't know if we can get that picture up. We've also got a picture last weekend, and Rob's also seen this down at the down at myotherapy down in Melbourne. We got a needle stuck in the fascia over their infraspinatus. And normally if you leave a needle for long enough, the body relaxes and the needle just comes out. This one didn't want to come out, so we just said, all right, we'll just stabilise the skin and we'll just reef it out. Okay, when we reefed it out, there was a massive pop, and then out of the hole was some superficial fascia that had popped out of the hole. Now, basically, over about 5 minutes, the body just reabsorbed that fascia back into the body. And Rob had I've only seen it once, and Rob saw it last year. Last year in the hammy. I haven't spoken to the girl yet. She's finishing off the workshop in a couple of weeks. I hope she is. Yeah, it's on your phone. It's on my computer as well, so you might be able to plug it in. But the guy come back to Rob the following week and said that it's the best his hammy's ever felt in ages. So I'm not saying that that's a treatment we should be heading down the line of. But certainly, yeah, it was something that I hadn't seen before. But people get blood taken all the time. Okay, yeah. So you know well, they do pierce them. Okay, you'd probably struggle to pierce something like the femoral artery. You tend to sort of bounce on it for a little while.
Sorry, what about the subclavian? I mean, not that you're working there, but it is. Oh no, look,
you do work in there, and I've seen someone when they're needling scalenes, and suddenly there was some blood running down the front of their chest. But they heal up really well. The main arteries that I steer clear of are the vertebral artery, so high up in that occipital triangle. Okay, and that's just mainly because you don't know the course of the vertebral artery. It's quite a flexible artery. It has to be for our head to move. Okay, so that's one I steer clear of. So like throughout the workshop, I go, look, you hit an artery. It's no big deal. You get out your cotton ball. I say mop it up, but that's just joking.
Knots or anything like that. Is there a chance of a clot at all?
Of a
clot happening, forming?
Yeah, there has been some instances where there was an instance recorded of someone actually causing acute compartment syndrome with acupuncture, and it's one of those ones where you read the abstract and you think that can't be correct because I use it for compartment syndrome all the time, and you think, I better go and read the article. And when you go and download the article and pay your $38 for it and read it, you realise that it was a GP. He'd used a hypodermic needle, and it was on an older client that was on blood thinners. And you sort of go, that wasn't acupuncture causes compartment syndrome, that should have been GP causes compartment syndrome. Okay, so it was just the perfect way that person could word the article to make it look like acupuncture does. But yeah, there's also been cases of obviously clots and deep vein thrombosis that get attributed to acupuncture or dry needling, just because sometimes it's easy to do that.
Yeah. So frustrating because people read the article and they say, oh, it's just acupuncture that does this, every dry needling does this.
Yeah. So like someone might get a DVT 3 days after acupuncture or dry needling, and it's very easy for the GP to say, what have you done recently? I had some dry needling. That'll be it.
Just remember, neck massage causes stroke. Everyone saw that, I'm guessing?
I was also told that massage over T5 causes a heart attack, so it's completely changed the way I do things.
All right, we'll have to leave it there, but what we'll do is we'll put that...
Do you want me to take these out before you start turning your head, Jimmy?
And then we'll put the video up. You can watch that while you have morning tea, then we'll have our next presenter, Trish Wisby-Roth, on. So 15 minutes.
Thank you, Jimmy.
I think your question You won't even bother ever asking that question again after you watch this video. Yeah. It's amazing.